Half of the people who will die from a heart attack this year had completely normal cholesterol levels. Normal. Clean. Nothing alarming. They went to their doctor, got their blood work done, and were told the same reassuring sentence millions of people hear every day. Everything looks fine. And then, weeks, months, or maybe a few years later, something happened that no one expected. A sudden pain in the chest, a collapse, an emergency room visit that changed everything. I've stood in operating rooms with those patients. I've looked at charts that said low risk, and then held a heart in my hands that told a completely different story. And the truth is uncomfortable, but it needs to be said. The warning signs were there. We just weren't looking at the right numbers. So before you relax because your cholesterol is normal, I want you to ask yourself one question. What if normal isn't enough to keep you safe? My name is Dr. Kevin Adewale. I'm a cardiac surgeon, and for more than 2 decades, I've spent my life inside operating rooms, working on the most vital organ in the human body. I've seen arteries that look like they belong to someone decades older than the patient lying on the table. I've seen blockages in people who exercised, ate well, and did everything they thought was right. And I've seen something else that stays with me after every difficult case. That moment when you realize this didn't happen overnight. This was building quietly for years, maybe decades. And somewhere along the way, there was an opportunity to catch it earlier. The problem is not that we don't test people. The problem is that we often rely on tests that don't tell the full story. The standard cholesterol panel is useful, but it's incomplete. It's like trying to understand a storm by only checking the temperature outside. You might see that it's warm, even comfortable, but you have no idea that a violent storm is forming just beyond the horizon. To understand why this matters, we need to go back a little. The cholesterol test most people are familiar with was developed decades ago, at a time when our understanding of heart disease was far more limited than it is today. Back then, discovering that cholesterol was linked to plaque buildup in arteries was a breakthrough. It gave doctors something measurable, something actionable. Total cholesterol, LDL, HDL, these numbers became the foundation of cardiovascular risk assessment, and to be clear, they helped save lives. But medicine evolves. Science moves forward, and what we've learned in the years since has revealed something important. Cholesterol itself is not the full picture. In fact, focusing only on cholesterol can sometimes give a false sense of security. Here's the key issue. The standard cholesterol test measures how much cholesterol is present in your blood, but it doesn't tell you how that cholesterol is behaving. It doesn't tell you how many particles are carrying it, how likely those particles are to penetrate artery walls, or whether your arteries are inflamed and vulnerable. 2 people can walk into a clinic with identical LDL numbers and leave with completely different futures. One might live for decades without a cardiovascular event. The other might experience a heart attack within a few years. And if you're only looking at the traditional numbers, you would never know the difference. That's why the statistic I mentioned earlier is so important. About 50% of people who suffer heart attacks have cholesterol levels that fall within what we call the normal range. That is not a small margin of error. That is a fundamental gap in how we assess risk. So, what fills that gap? This is where things start to change. Over the years, research has uncovered additional markers, tests that go beyond basic cholesterol and reveal what's actually happening beneath the surface. These tests don't replace the standard panel. They complete it. They add depth, clarity, and precision. And today, I want to walk you through 3 of the most important ones. Not in a technical, overwhelming way, but in a way that makes sense, that you can remember, and that you can act on. Because information only matters if you can use it. The first test is something called high-sensitivity C-reactive protein, or CRP. This is not a cholesterol test at all. It's an inflammation marker, and inflammation is one of the most underestimated drivers of heart disease. When most people think about blocked arteries, they imagine fat slowly building up until it clogs the vessel like a pipe. But that's not quite how it works. The real danger is not just the presence of plaque, but the stability of that plaque. Some plaques are stable. They sit there, hardened, relatively quiet. Others are unstable. They're inflamed, fragile, and prone to rupture. And when a plaque ruptures, your body responds by forming a clot. That clot can block blood flow almost instantly. That's a heart attack. CRP is essentially your body's way of signaling that inflammation is present. When levels are low, it suggests a relatively calm internal environment. When levels are elevated, it's a sign that something is happening beneath the surface. Not necessarily a heart attack in progress, but a condition that makes one more likely. What makes CRP particularly valuable is that it can be influenced. Unlike some risk factors that are fixed, inflammation can be reduced. Regular physical activity, consistent sleep, a diet rich in whole foods and low in processed sugars, and managing stress all play a role. I've seen patients bring their CRP levels down significantly within a matter of months, not through extreme measures, but through consistent, sustainable changes. And that's important because it means this is not just a diagnostic tool. It's a lever you can actually pull. The second test is called LPA, or lipoprotein A. This one is very different. If CRP represents something you can change, LPA represents something you inherit. It's largely determined by your genetics and remains relatively stable throughout your life. About 1 in 5 people has elevated LPA, and most of them don't know it. They can have normal cholesterol, a healthy lifestyle, no obvious warning signs, and still carry a higher risk of cardiovascular disease. I've had patients who did everything right, who looked like the picture of health, and yet they ended up needing surgery. When we look deeper, elevated LPA was often part of the explanation. What makes LPA particularly challenging is that lifestyle changes have limited impact on it. You can't significantly lower it through diet or exercise, and that can feel frustrating at first. But knowing your LPA level is still incredibly valuable because it changes how aggressively you manage other factors. If you know you have a higher baseline risk, you pay closer attention to everything else. You keep your LDL lower. You monitor inflammation more carefully. You stay proactive rather than reactive. It's not about fear. It's about awareness, and awareness gives you options. The third test is apolipoprotein B, or ApoB. This is the one that often changes how people think about cholesterol entirely. To understand ApoB, you need to shift your perspective slightly. Instead of asking how much cholesterol is in your blood, you ask how many particles are carrying that cholesterol, because each of those particles has the potential to enter artery walls and contribute to plaque formation. ApoB measures the number of these particles, not their weight, not their size, but their count. And in many cases, that count is a more accurate predictor of risk than LDL alone. Think of it this way. Imagine 2 highways carrying the same total amount of cargo. On one highway, that cargo is distributed across a small number of large trucks. On the other, it's spread across a large number of smaller vehicles. The total weight is the same, but the number of vehicles is very different. And more vehicles mean more opportunities for collisions. ApoB tells you how crowded that highway really is. And in the context of your arteries, more particles mean more chances for damage. What makes these 3 tests so powerful is not just what they reveal individually, but what they reveal together. They provide a more complete picture of cardiovascular risk. CRP tells you about inflammation. ApoB tells you about particle burden. LPA tells you about genetic predisposition. When you combine them, patterns begin to emerge. You can identify whether risk is driven by lifestyle factors, genetic factors, or a combination of both. And that level of insight allows for more targeted, effective decisions. Now, I want to address something that often comes up at this point. People ask, if these tests are so important, why aren't they part of every routine checkup? The answer is complex. Medicine is a balance between thoroughness and practicality. Doctors have limited time. Guidelines evolve slowly, and for many patients, the standard panel still provides useful information. But that doesn't mean you shouldn't ask for more when it makes sense, especially if you're over 60, have a family history of heart disease, or simply want a clearer understanding of your health. Advocating for yourself doesn't mean challenging your doctor. It means participating in your care. A simple request for additional testing can open a conversation that leads to better decisions. And a good physician will welcome that conversation. Because at the end of the day, the goal is the same for both of you, to keep you healthy, informed, and out of the operating room. There's something I've learned after years in this field. The most dangerous phase of heart disease is not when symptoms appear. It's the long, silent period before that. The years when everything feels normal. When energy levels are good, daily life continues as usual, and there's no reason to suspect anything is wrong. That's when the disease is quietly progressing. That's when early detection matters most, because once symptoms show up, The situation has already advanced. I don't say any of this to create fear. Fear doesn't help. It clouds judgment. What I want to give you is clarity, because clarity leads to action, and action, taken early, can change outcomes. I've seen it happen. I've seen patients who caught issues early, made adjustments, and avoided major events. Not because they did something extraordinary, but because they had the right information at the right time. So here's what I want you to do. Before your next doctor's appointment, write down 3 things. High sensitivity CRP, LPA, ApoB. Take that list with you. Ask about them. Start the conversation. That's all it takes. One step, one question, one decision to look a little deeper.